Hi, I'm Andy Rosenkrantz, the editor-in-chief of AJR, and I'm here today with Dr. Paul Bunch, an assistant professor of radiology at Wake Forest, and he'll be discussing with us his recently published AJR article on opportunistic CT assessment of the parathyroid glands. Dr. Bunch, thank you for joining us.
Thank you for having me. It's a pleasure.
To start off, please summarize for us current paradigms for diagnosing and treating primary parahyperthyroidism.
Sure. So most patients who are ultimately diagnosed with primary hyperparathyroidism are first noticed to have an elevated blood calcium level. And if that is in fact noticed and considered an issue worth investigating by his or her physician, they're also undergo parathyroid hormone level testing. And so if the parathyroid hormone level is either inappropriately normal or elevated, they're typically given this diagnosis of primary hyperparathyroidism, which is treated with surgery to remove the abnormal hyperfunctioning parathyroid glands.
So that nicely covers the clinical aspect. What is the current role of imaging?
So the current role of imaging in this disease is a patient will come for an imaging study after being given the diagnosis, and kind of the imaging study is designed to help identify the location of the abnormal gland or glands to facilitate a successful surgery.
Let's now turn to the study at hand. This was retrospective, but it relates to something that the radiologists were putting in their reports as part of clinical care. Can you please explain for us just what the radiologists were doing?
Yes, so based on some earlier preliminary studies that we did, we kind of stepping back a little bit, we got interested in this question of, can we identify abnormal parathyroid glands on routine CT studies? Lots of CT scans are done for all sorts of reasons. The parathyroid glands in theory are on those studies. And so can we identify them? And if we do see them and we recommend blood testing, can we ultimately identify people who have not yet been diagnosed with parathyroid disease? And so at our institution, neuroradiologists familiar with that work and kind of buying into the idea started looking for these glands, and they tend to be hypoattenuating to the thyroid because they don't have iodine in them on the non-contrast phase, and they tend to enhance differently from lymph nodes. And so when a neuroradiologist in clinical practice saw something in the neck near the thyroid in the central compartment that didn't look like thyroid gland or lymph node, oftentimes they report that as a possible enlarged parathyroid gland, and they recommend consideration of blood testing, biochemical testing for possible parathyroid disease. And so that's kind of what the radiologists were doing as a component of their clinical practice, informed by some earlier data.
With that context in mind, what was the process used to find patients for the sample in the present study?
Sure. So we have a particular kind of informatics tool that allows us to search radiology reports, like I know a lot of people do around the country at various medical centers. And so we kind of designed a search to look for the phrase recommend correlation with biochemical testing for possible primary hyperparathyroidism. That's kind of the phrasing that our group had been using if we did see something of concern and thought that it should be correlated with blood testing. And so performed that search to identify a subset of CT examinations done between 2019 and 2021. And that was kind of where we started.
Right. And just what kinds of exams were these?
Yes, so these it was heterogeneous, but they were all CT examinations interpreted by a neuroradiologist. And so there was a group that were like kind of contrast enhanced CTs of the neck, done, for example, for head and neck cancer surveillance or staging. There were some CTAs done either for suspected dissection, done for suspected stroke. And then there were some trauma CTs, also cervical spine or thoracic spine, including the area of interest.
Of these cases, you then found a subset of patients who later underwent laboratory testing. Can you explain how that worked?
Yes, and so the methods involved kind of a deep dive into the electronic health records. So in the course of their clinical care, they received this recommendation that was of interest to us. But as probably the listeners are aware, not all radiology recommendations are heeded. So only a subset of those actually received the blood testing. And in this study, the two tests of interest were serum parathyroid hormone level, and then also serum calcium. And so we looked to see who got those blood tests done after this recommendation was offered on the imaging study. And those were the patients that we considered tested for study purposes. If they did not receive those, they were considered untested.
For patients who did undergo testing, a surgeon then did an additional review of the EHR and did some classification. So how did that work?
Right. And so my co-author, Dr. Reese Randall, an endocrine surgeon with quite a bit of experience diagnosing and caring for patients with this disease, we kind of delegated that task to him, feeling like he was the appropriate expert. And so he looked at the results of those laboratory tests, number one, but then he also looked for comorbidities known to be associated with this disease of interest, primary hyperparathyroidism. So kidney stones, fractures, osteopenia, osteoporosis, things like that, decreased EGFR. And that helped him decide, does this patient, both from the blood testing and then the other things they have going on, have a diagnosis of primary hyperparathyroidism versus maybe secondary hyperparathyroidism, or maybe there was no evidence of a parathyroid disorder at all. Everything looked normal on the laboratory testing. That was also a possibility that we wanted to be open to.
Let's now turn to the results. How many patients did you find who had a suspected parathyroid lesion, and how many of those underwent testing?
Yes, so 39 patients ultimately were included in the study, and of those, 13 received the recommended testing. Of those that did not receive testing, there were just a couple who it was ordered for, but they never underwent it. But in 13 of the 39 included patients, we had kind of the full laboratory results that we were looking for.
And you looked at this, of those 39 cases, what percent of all exams was that performed during the study period?
It was a very, very small percentage. So as you can imagine, we're busy, just like many folks out there are. There were over 31,000 CT examinations of the type of interest that there were ultimately received the recommendation performed in the study period, and only 39 actually received that recommendation. So it's 0.1% or so.
Of the patients tested, how many actually had parathyroid disease?
Yes, so it was 7, I believe, had some form of parathyroid disorder. 3 of those had primary hyperparathyroidism, and 4 of those had secondary hyperparathyroidism. So kind of referring to my notes here a little bit, it was just over 50% had a recognized parathyroid disease, but only a subset had primary hyperparathyroidism, the primary form of interest.
So based on those numbers in the article, you calculate numbers needed to recommend and numbers needed to treat. So can you comment on that?
Yes, so we kind of two things we were interested in. One, how many recommendations does the radiologist need to make to yield a single correct diagnosis of primary hyperparathyroidism? And then how many people actually have to undergo testing to yield a single correct diagnosis of primary hyperparathyroidism? And so, it was basically number of recommendations over number needed, or number of with true disease. So that ended up being kind of 39 over 3, or 13.0. And then number undergoing testing, which was the 13 over the 3, and it comes up to a little bit more than 4. And so it's hard to test a fraction of a person, so you could round that up to 5 maybe for consideration in your practice.
You and your team have published a good amount on imaging of parathyroid disease. What are you planning next?
So we have a lot of ideas for things to do next. I think we're still sort of in the space of, stepping back for a second. The hope is that we can find something that radiologists can offer, not just in the localization of this disease, but in facilitating correct biochemical diagnosis. And it's something we don't have time to go into in depth, but there's a lot of literature on current paradigms not working well for patients. There being a lot of hypercalcemic patients out there who are never tested for this disease, and then even patients with known disease are never referred to even have a conversation with a surgeon. So there are a number of well-documented gaps that our hope is radiologists could play a role in helping close. And I would say, I think we're still sort of in the could this potentially work phase, and hopefully we can eventually move to the does this work phase. And so an important question that our study here sheds some light on is just how big of an impact might this have, or how many people out there who are at risk for undiagnosed disease actually have the CT imaging of interest. So one study kind of in the pipeline is looking at people who we would consider to be at risk based on having elevated calcium, and seeing how many of those, what proportion of those have a CT scan that someone could look at and potentially see something. And so that's a question to be determined. But that's one study of several that we've got that we'd like to look at next.
And returning to the study at hand, any key limitations for our listeners to recognize?
Yes, absolutely. No study is perfect, and this study is certainly far from perfect. So, it was a very small number of patients ultimately included, and it was a retrospective study. Other limitations include the fact that we only know what was described in the reports. So we don't know were there potentially large parathyroid glands that were not identified, that were missed. We have no mechanism for capturing that. And another question that we hope to get to in short order is kind of inter-rater reliability, and then also intra-rater reliability. If you look at these studies, separated in time, how often do you agree with yourself even? And so those were things that were not assessed in this design. There are several other limitations that I would also characterize as important that we include in our discussion, but those are some of the ones that I think are worth highlighting for the listeners.
Any final takeaway about the article?
I think for me, the takeaway at this point is I would like people to realize that the parathyroid glands are on these images that you're interpreting, whether you realize it or not. And I don't know that there is yet great justification for spending extra time or making sure this is always part of your search pattern. If it's a code stroke CT, focus on the brain, focus on the blood vessels, take care of the patient. But if you see something in the central compartment that doesn't look like thyroid, doesn't look like a lymph node, think about, could this be an enlarged parathyroid gland? And if you find yourself having that consideration or asking yourself that question, I think there is some evidence that recommending some blood testing, relatively low risk, relatively low cost, could make a difference for that patient.
Dr. Bunch, I really appreciate your joining us today and sharing your insights with us.
Thank you for having me. And I'd like to just acknowledge my co-authors, Dr. Swetha Arabendi, Dr. Matthew Goris, Dr. Reese Randall, as well as the AUR Giraffe program for supporting our work.